This lesson is about junctional rhythm. But before we talk about junctional rhythm, let's do a quick review of the electrical conduction system of the heart. This is the SA node. It's the primary pacemaker of the heart. It produces sinus rhythm, and it paces at a rate between usually 60 to 100 beats per minute. The AV node is right here. The AV node is a secondary pacemaker, and it produces junctional rhythm, which is what we're going to talk about today. So if the SA node is unable to pace the heart, fortunately your heart has redundancies in place, like the AV node, and the AV node can then pace the heart at a range of 40 to 60 beats per minute normally. And of course, if neither the SA node nor the AV node are able to pace the heart, the ventricles can pace the heart, but at a lower rate still, between 20 to 40 beats per minute. Now let's take a look at what's actually happening inside the heart, and also simultaneously what we're seeing on the ECG paper. We're going to take a look at the heart from, now we have 12 leads to choose from, but we're going to go ahead and choose lead 2. Lead 2 looks at the heart in this direction. It has a positive electrode down here, and anything that's moving away from the positive electrode is therefore negative. So let's look at our paper. Let's draw an isoelectric line down here. Isoelectric, and it is isoelectrically neutral, so essentially having 0 amplitude. And anything above that line is a registered positive deflection, and anything below that line is a registered negative deflection. So when the SA node initiates depolarization of the atria, polarizes in this direction towards the positive electrode, resulting in a positively deflected P wave. Then the depolarization travels down through the AV node, down the bundle of His, and depolarizing your ventricles by way of the right and left bundle branches. And of course, that's also moving in a positive direction towards the positive electrode, resulting in a positively deflected QRS. And then your T wave, of course, represents ventricular repolarization. Now, on the ECG paper, you will see large boxes and small boxes. And just as a review, you can see the large boxes like that. And I will draw another QRS on here, just as an example. Now, each box, each large box, represents 0.20 seconds. And within each large box are a bunch of little boxes, five small boxes moving horizontally and vertically. Now horizontally, of course, all these are measurements of time. Now, if we want to determine the rate of a rhythm, the easiest way to determine that, based on just looking at the paper, is looking at how many large boxes are between R and R's. And you take the number of large boxes between R and R's, and then you take 300, and you would divide by that number. So 3 large boxes between R to R's would equal 100 beats per minute. So that's just a quick review, just to refresh our memory before we move on. So now we're going to talk a little bit about junctional rhythm characteristics. And how do we define junctional rhythm characteristics? So Junctional rhythm, just like normal sinus rhythm, normal junctional rhythm, it has a regular R to R interval. So there's equal spacing between the R to R's. And we just said before, the AV node paces between 40 to 60 beats per minute. So junctional escape rhythm is between 40 to 60 beats per minute. PR for sinus rhythm, if you remember, is between 0.21 and 0.20 for a normal PR. Now junctional would be considered less than 0.12 if there is even a PR, and we'll talk about that in just a little bit. P-wave morphologies. Now this can be something that's very confusing about junctional rhythm, are the different scenarios in which you can see the P waves. So P waves can be inverted, they can be hidden, retrograde, or upright and short. And we're going to talk about those in just a minute. Now the QRS width should be relatively narrow for junctional rhythm. And when I say relatively narrow, this is what I mean. Now if your patient, let's say they're in sinus rhythm, you can see they have an upright P wave, narrow QRS, they're in sinus rhythm, and then they convert to junctional rhythm. We'll just say they have a hidden P wave. So there's no P wave there. Now if you look at the QRSs, they look virtually identical. And the reason for that is that here's the AV node. When the AV node depolarizes the ventricles, it also travels down through the bundle of His, the bundle branches, depolarizing the ventricles in the exact same way that happens in sinus rhythm. Now when I say relatively narrow, what I mean is that if the patient was in sinus rhythm, but they had, say, a bundle branch block, so to exaggerate that a little bit, then they converted to junctional rhythm, it's going to be the same. We'll still have a bundle branch block. In junctional rhythm, the QRS should be the same as before, so relatively narrow, or relative by comparison to what they were when they were in sinus. Okay, now let's talk about P-wave morphologies. Now, we'll talk about inverted P waves first. So why would the P wave look inverted? Well, let's use our lead 2 again as an example. Remember, looks at the heart like this, positive electrode. So anything moving that way would be negatively deflected. So I'm going to draw an isoelectric line. Positive, negative. Okay. So in junctional rhythm, our depolarization is coming from the AV node right there, which is basically right in the middle. So it's going to depolarize the atria from the bottom up, like this, which is moving in which direction? It's moving away from the positive electrode. So on the paper, it will show up as a negative deflection. Now, ventricular depolarization happens the same way it would in sinus rhythm, we just mentioned before. So it travels down towards the positive electrode, resulting in a positively deflected QRS. Now, since the depolarization is happening essentially right in the middle of the conduction system, the P wave, when it's inverted like this, the PR should be reasonably short, usually expected to be less than 0.12. And that is how it would show up if the P wave was inverted, and why. So let's move along to what happens if there is no P wave. So if the AV node depolarizes the atria and the ventricles simultaneously, what's that going to look like? Well, if we just show ventricular depolarization, now just using kind of a ladder diagram, I'm going to draw what the atria is doing underneath. So the P wave is going to be hidden and eclipsed by the QRS complex. So what you're going to see is just this. The P wave will be hidden inside this complex, and you won't be able to see it. So that's a scenario that would cause the P wave to be hidden. Okay, retrograde. What's retrograde? Well, if the ventricles depolarize slightly before the atria, then you have ventricular depolarization followed by this late P wave that sometimes you can see, sometimes it's hard to tell. But that is what we call a retrograde P wave, when it happens afterwards. Now, upright and short. This can get a little confusing, but what's happening here is this. This is the SA node, and patient's in sinus rhythm, and it starts depolarization. SA node starts depolarization. However, before it reaches the ventricles, the AV node initiates depolarization, which produces something that looks like that. So it's kind of a fusion of the two, and that we'll see more of when we start talking about accelerated junctional rhythms. Okay, here is a junctional rhythm strip. So take a minute, look at it, and let's apply what we've learned. Okay, so we know that under our rhythm characteristics, we would expect the rhythm to be regular. Looks pretty regular to me. It's like even spacing. So what's the rate? Good question. Now, we know that for rate, we want to take the number of large boxes between R to R's, and then we want to take 300 and divide by that number. So it looks like there are 1, 2, 3, 4, 5, approximately 6 large boxes. So we divide that by 6, and we get 50 beats per minute. So we know our rate just by looking at it. So the rhythm is regular. Let's put yes. The rate is 50 beats per minute. What about the PR? Well, PR looks pretty short. I would probably say maybe 0.10. And that's definitely less than 0.12. P waves. All right, so are those P waves upright or are they inverted? They look pretty inverted to me. Hopefully you can read that. Inverted. Okay. And the QRS. Is the QRS narrow or wide? Well, looks reasonably narrow. It's like maybe 0.08, 0.10 at the most. Narrow. All right. So I would say based on our EKG characteristics that this is definitely junctional rhythm. Now, what are some of the causes for junctional rhythm? Well, obviously, slow heart rate is the main cause, right? Slow heart rate or the SA node's inability to pace the heart, because that's what it's supposed to do. It's a redundant pacemaker. So, slow heart rate. So, sinus bradycardia. If the SA node is pacing too slowly, then if it's pacing, well, let's see, the sinus rhythm is normally between 60 to 100 beats per minute. So the slower the SA node paces, the more likely that the AB node can outpace it. If the SA node starts to pace down lower into the 40s, 50s, 40s range, the likelihood that the AB node may be able to outpace it increases. Sinus arrest. The SA node is not functioning. It ceases to pace. So, sinus rhythm, and then nothing. And then at that point, you would hope that the AB node takes over and begins to pace the heart. And heart block. And we haven't talked about this, but if there is a block in conduction through the AB node, then the bundle of His can pace the heart and take over. But we're not going to go into that right now. Okay, let's talk about sinus bradycardia just for a minute and look at this example strip. Now, here's an example strip you can take a look at and just see what you think about that. Just analyze it, look at and use the characteristics we've learned. So it looks like you see P waves. There's one. There's one. Every QRS has a P wave, it looks like. There's a 1-to-1 ratio. Except for here. I don't see a P wave there. I wonder why. Well, let's take a look at the rate. So, patients in sinus rhythm. This is the first R to R interval that I see. And it looks like there's about 4 large boxes in there. So we'll take 300 and divide it by 4. And that's going to come out to be 75 beats per minute. So they're in normal sinus rhythm. Everything's great. But then their heart rate slows way down. You see the R to R intervals getting longer and longer. So let's measure this. How fast is that right there? Looks like I have approximately 6.5 boxes. So I'm going to take 300, divide it by 6.5, which is about 46 beats per minute. So the heart rate, the SA node, the pacing of the SA node slowed down considerably, well into the range where the AV node may be able to outpace it, which is what you're seeing over here. You're seeing a junctional escape beat, or sometimes just abbreviated like this, Now, the rhythm strip is cut off, so we can't see what continues, but this could be just one beat all by itself, and then the patient could go back into sinus rhythm, or it could continue on if the SA node just slows to the point where it ceases to pace. Then you would, hopefully, you would carry on with a junctional escape rhythm, hopefully in the range of 40 to 60 beats per minute. All right, and that's an example that is not uncommon. When someone's heart rate slows way down, you can see junctional escape beats or episodes of junctional escape rhythm for short intervals. And it may be that the SA node and the AV node are pacing close to the same rate, and so you may see some switching back and forth. Okay, sinus arrest. Now in this scenario, the SA node is stop pacing. Let's take a look at the rate, what it was before. So it looks like about 4.5 boxes, I'm going to just say. So 300 divided by 4.5. That's about 67 beats per minute, something like that. But then, where I would expect to see another P wave, about here, there's nothing. So the SA node fails to pace. And as a result, you are in sinus arrest until the AV node paces the heart. And it looks like I have a hidden P wave. So the AV node finally was able to pace the heart. Has a relatively narrow QRS. And it will continue to pace the heart. Let's see what rate it's pacing at. Oh, it's about 7.5 boxes, I think. So, say 300 divided by 7.5 equals 40, about 40 beats per minute, something like that. So pretty slow, but it will keep you alive, and that's its whole purpose. Okay, so we've talked about the AV node pacing, producing junctional rhythm or junctional escape rhythm as a result of the SA node not being able to pace the heart appropriately. But the AV node can also pace the heart inappropriately. It can interrupt sinus rhythm and pace when you wouldn't expect it to. So here is an example strip of what we call a PJC, premature junctional contraction. Just one PJC, and you can see that if you follow along the rhythm strip, you'll see sinus rhythm. There's our upright P waves, narrow QRSs, until we get right there. We have a beat that comes early, and I can distinguish this as a PJC versus simply saying a PAC, or premature atrial contraction. And I'm going to say PJC because there is an inverted P wave right there, an early inverted P wave. And that is an indication to me that the AV node initiated this by depolarizing the atria early and in a way that's opposite that of the normal sinus rhythm. So it looks like a PJC occurred, and that's what interrupted this. And you can have one of these, you can have lots of them, it just depends. So let's move on and talk about accelerated junctional rhythm. Accelerated junctional rhythm has all the same characteristics that junctional escape does, for the most part. It initiates the polarization from the bottom up, and the ventricular depolarization in the normal way. So all the other characteristics are essentially the same, except that accelerated junctional rhythm paces, as you might have guessed, faster. It paces between 60 to 100 beats per minute. And the strip below is an example of accelerated junctional rhythm. So we can evaluate it by looking first, we'll look for the P waves. And I don't see any P waves anywhere. Looks like they're hidden. The QRS is pretty narrow. Looks like maybe 0.08, something like that. Pretty narrow QRS. So that excludes it from, like, let's say you were trying to look at a rhythm strip and the rate was slow and there were no P waves, so you're thinking, okay, is this idioventricular rhythm? Well, idioventricular rhythm is a ventricular rhythm, and it's very wide, has a wide QRS. So you can tell immediately that this is not idioventricular rhythm because the QRSs are narrow, and you can tell it's not sinus rhythm because there are no P waves. So as a result, it must be junctional rhythm. So let's determine then if it's junctional rhythm, like junctional escape rhythm, or if it's accelerated junctional rhythm. So I will measure the rate. Looks like about 4.5 large boxes. So 300 divided by 4.5 equals about 67 beats per minute. So that does fall within the range of 60 to 100. So that qualifies as accelerated junctional rhythm. All right, here is another example of accelerated junctional rhythm. And I wanted to show you this because this shows how accelerated junctional rhythm may overtake the pacing of the SA node. And it shows you the example I talked about earlier, where the P waves are merging into the QRS complex. Now, I can see the patient is in sinus rhythm. Looks like they have upright P waves. But one thing that you notice about this is the PR is getting smaller. Until it is almost not even visible anymore, and then it completely disappears. So what's happening here is like the example we talked about earlier, where the SA node is pacing, initiating depolarization of the right and left atrium, and you can see that SA node, and here's the SA node again, but before the SA node is able to finish the entire cardiac cycle, the AV node paces. Which is why your QRS is, or why your PR is actually getting shorter, because the AV node is gradually outpacing the SA node. And this isn't completely uncommon. We see this somewhat regularly. I mean, with accelerated junctional rhythm, often it happens like this. And you can see it go back and forth. If the SA node is pacing at a similar rate to the AV node, you may see them go in and out of accelerated junctional rhythm. It happens. It gets a little confusing, but this is what's happening when you see that. Okay, junctional tachycardia. Let's take a look at this strip and just take a look at it for a minute and see if you can see where the P waves are. If you look closely, you don't see anything in front of the QRS, but you can see what looks like retrograde P waves afterwards. So this is an example of junctional rhythm with a retrograde P wave. So ventricular depolarization is happening just slightly before atrial depolarization. Now, junctional tachycardia is the same as accelerated junctional, except that it paces even faster, greater than 100 beats per minute. And this can be hard to identify sometimes because when the rate increases up to 120, 130 beats per minute, it's hard to tell whether there's a P wave in front of the QRS or not. Now, with this example, it's pretty easy to see the retrograde P wave. It's right after the QRS there. But as the rate increases, the P wave, it's hard to tell whether there's a P wave stuck in the T wave or, it can be hard to see. Now the rate, let's check the rate of this. Looks like we have, it's just slightly, you can see it's just slightly less than 3 large boxes. So I'm going to go ahead and say 2.9. 2.9 large boxes. So that's about 103 beats per minute. So just over the line. And that's junctional tachycardia. So what causes this? Why would the AV node pace faster than it's supposed to? Well, you can have, let's think about for a second what regulates the rate at which it paces. The action potential of those cells of the AV node, that regulates how fast they pace. And a number of things can influence those action potentials. Tissue damage, for example, like during surgery. Tissue damage can disrupt those cells and cause those action potentials of those cells to change. Maybe it causes them to polarize at a faster rate than they're supposed to. Myocardial ischemia. If the blood supply to those cells is cut off, it will also impact how those cells function. It will impact the action potentials of those cells, causing them to pace faster than maybe they normally would. Myocarditis, inflammation of the myocardium, that can also impact the function of those cells and how rapidly they pace. And then medications, of course, can impact those cells and to cause a specific outcome. So all of those things, and we're not going to talk about medications right now, but all of those factors can play a role in what would cause the AV node to pace faster than it's supposed to. Okay, now here's a real strip. It's kind of grainy, but this is an actual strip that you would see. And the practice strips and the real strips, they can, if you're going back and forth, sometimes they can be confusing. So real strips are they take a little getting used to when you've been studying on the practice strips. Now, looking at this strip, let's just evaluate it based on what we've learned. So looks like the R&R intervals, pretty regular it looks like. So regular, yes, I'm going to say that it's regular. What is the rate? Well, the computer will tell you. So that's kind of handy. You don't need to do any math. Heart rate is 76 beats per minute. PR. Well, is there P waves? I mean, are there P waves anywhere to be seen in this strip? I don't see any here. I don't see anything here. This appears to be a U wave, so we wouldn't count that. So I don't see any P waves. It looks like the P waves are hidden in this strip. Let's say NA, and P waves are hidden. And QRS, well, QRS is not exactly narrow. It's not really, really wide either. It's kind of hard to see on the strip how exactly what the P or what the QRS interval is, but I'm going to say that based on the rate, it's 76 beats per minute. I don't think this is an idioventricular rhythm, so I'm going to go ahead and say that they probably are in have accelerated junctional rhythm with a bundle branch block. And I actually, since I took this strip, I happen to know that's exactly what they were in. All right, let's move on to another real strip. Okay. Let's evaluate this one. Let's take a look at it for a second. Okay, R to R intervals. Look pretty regular to me. And the one thing to look at when we're talking about regularity in junctional rhythm, sometimes it can be difficult to identify the difference between fine AFib and junctional rhythm for some people that are just learning. Because when you have fine AFib, the baseline, coarse AFib, the baseline looks chaotic, and it's really easy to tell, AFib. That's my crude drawing of AFib. But when you have fine AFib, there's just a little ripple to it. And the rhythm is, because AFib is very irregular. So identifying the difference between sometimes fine AFib and junctional rhythm can be a struggle for people just learning about heart rhythms. But AFib is very irregular. The R to Rs are very irregular. So if the R to Rs are perfectly regular and you don't see any P waves, then and the QRS of course is relatively narrow, you're probably looking at a junctional rhythm. But if the R to Rs are extremely irregular, then you may want to consider fine AFib. And that's really what I'm looking for when I see the regularity of these. Okay, so rate. Well, once again, computer tells us it's 100 beats per minute. Okay, what is the PR? Is there a PR? Well, I don't see any P waves in front here on either of these leads. So we're looking at 2 and B2. But it looks like, if you look at the very back here of that QRS, and you kind of follow the different, like compare it to this QRS, it looks like there's something maybe right there. Like maybe there's a retrograde P wave in there, I think. So let's say NA for PR, P waves, retrograde. And the QRS looks pretty narrow. So the rate is 100 beats per minute, so accelerated junctional is 60 to 100. So we can call this accelerated junctional rhythm with retrograde P waves. All right, next real strip. Now this can be very confusing for people. Let's look at the R to Rs. Are the R to R's perfectly regular in evaluating this strip? Well, not completely. I mean, mostly, but it kind of looks like it speeds up a little bit. Looks like the rate speeds up a little bit as we go this way. So yes and no. I'm just going to say that's not applicable right now. Let's move on to the rate. It's like 88 beats per minute. Okay, and the PR, now this is where it gets tricky. Let's look at the PR. There's the PR, just drawing it underneath here. But then it gets shorter, almost non-existent, and then it just disappears. And there's nothing. And then, looks like if you compare, like look right here, compare that QRS to right there. You see right here, there's a retrograde P wave. There, right there, right there, and right there. So, and then you can see it come out here. So you can actually see the AV node is outpacing the SA node, and then it comes back out of it, out here. So there's this competition with the SA node and the AV node. So the PR is variable in this strip. And the P waves, well, they're upright when they're visible. So we won't really label that right now because they're short, they're merging, they're hidden, they're retrograde. It's all of it. And the QRS, well, we'll say that that's relatively narrow. So this is an example of accelerated junctional outpacing the SA node. Okay. Here's another strip. And you can see right here, this says 106 beats per minute. R to R looks pretty regular. PR, do we have a PR? Well, I don't see the obvious P waves in here or up here. That's NA. P waves. All right, so take a look and see where do you think P waves are. Well, it looks like you can see a retrograde P wave right here. Okay, so P waves are retrograde, and the QRS is relatively narrow. So based on the rate and that we have a retrograde P wave, I'm going to say this is junctional tachycardia. Okay, and this is our final rhythm strip. Now, I drew some lines in here to kind of help you follow where these P waves are. So you can see I've drawn these lines across there in the middle, And because this gets very confusing. So you see here, here's a P wave, and then everywhere that there's a little line above it, that's the atrial rhythm. So you can see a P wave there and there. Everywhere where there's a little mark, there's a P wave either hidden or visible, and you can follow it through. Now, what I'm looking at here is I'm looking at the atrial rate here and the ventricular rate here. And you can see that the atrial rate is actually slower than that of the ventricular rate. Now the ventricular, or the QRS, is reasonably narrow, and it's outpacing the atrial rate. So this is a case, again, where the AB node is pacing faster than the SA node can pace. And so you have this kind of a competition between the AB node and the SA node. So when you see this, that's what's happening. The AB node is outpacing the SA node, causing the ventricular rate to be faster than the atrial rate. And this does get confusing, but this does happen. And the RRs, they're somewhat regular, I suppose, but I'm just going to put NA because it's not really doesn't really matter right now. The rate, it's like, that says 93 beats per minute. And the PR, oh, well, that's variable. The P waves, once again, upright, short, hidden, retrograde, all of the above. And the QRS is, well, I'll say it's relatively narrow. So as you can see, junctional rhythm and accelerated junctional rhythm can be somewhat confusing. And understanding the relationships between the QRSs and the P waves may help you understand and figure out when you have rhythm strips like this that seem confusing. But when you look at a rhythm strip like this, I'm seeing that the QRS rate, or the ventricular rate, is faster than that of the atrial rate. So you're seeing this dissociation of P waves to QRSs, not because the SA node is not pacing fast enough, but because the AB node is actually outpacing it, resulting in this accelerated junctional rhythm.